The average person spends a third of their life asleep, usually in bed, with their bodies at a complete state of rest. I probably sound like a mattress commercial right now, but I'll tell you that that's not why this is important. It's important because even when your body looks completely relaxed, your mind is moving in and out of various stages of activity, triggering the release of hormones, encoding new memories, and even when it looks like you're not moving, your mind is engaging your muscles. Most of the time, this is routine, normal brain signals of sleep. But a lot of the time, more often than you might think, these brain signals can get mixed up. Recording from Studio 3 in Philadelphia, I'm Jim Sigler, and you're listening to Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that come with it. And this week on the show, we're going to review REM Sleep Behavior Disorder and its implications. Stay with us. This week on the show, I'm speaking with Dr. Lloyd Avidan.
Jim, can you hear me?
I happened to come across some of Dr. Avidan's work last year as I was doing some personal research on parasomnias. My daughter, Sophia, was starting to have some nightmares.
My name is Lloyd Avidan. I'm a neurologist. I specialize in sleep medicine, and I direct the UCLA Sleep Disorder Center.
I asked Dr. Avidan to join me, not for a discussion on nightmares in childhood, which is a common phenomenon of REM sleep, but to discuss pathologic phenomena of rapid eye movement sleep.
First, allow me to thank you for inviting me to speak on your podcast.
Well, thank you so much for joining me. And some of these disorders of sleep can be completely benign, hypnic jerks, for example, while others could be indicative of a looming neurodegenerative condition.
As a neurologist, we often see patients who experience abnormal behaviors during the night, which often help predict neurologic conditions, which is a really fascinating facet of sleep medicine. So I'm delighted to be on the show and speak on these conditions.
But before we get into REM sleep and disorders that emerge only during the 90 minutes each of us spend per night during this stage of sleep, let's go over a few of the basics, like what is a sleep disorder or parasomnia, what they are. But can you give us an overview of what a parasomnia is and some examples?
Parasomnias are abnormal behaviors or experiences that occur during sleep or sleep-wake transition. As an example, nightmares are a specific type of a rapid eye movement parasomnia. The nightmares occur during rapid eye movement sleep, and they generally include a specific experience in response to a dream. So that's a REM parasomnia. And non-REM parasomnia is one in which the patient experiences the behavior during slow wave sleep, for example.
Unlike nightmares, which occur during REM sleep, sleep terrors would be a non-REM parasomnia equivalent, occurring only during slow wave sleep, in which you spend about 6 or so hours each night.
And generally have amnesia as part of the clinical symptomatology. Patients do not remember those events. Other examples of non-REM parasomnias include sleepwalking, confusional arousals, sleep-related eating disorders, and even sexsomnias, which are abnormal sexual behaviors occurring in the context of a confusional arousal.
And returning to REM sleep parasomnias, there's isolated sleep paralysis,
where the patient wakes up paralyzed.
This is due to an abnormal prolongation of skeletal muscle suppression, which is normal during REM sleep.
During REM sleep, our body is essentially paralyzed.
But obviously, central paralysis is not normal during wakefulness.
They cannot move, and it's usually in the setting of sleep deprivation.
And lastly, REM sleep behavior disorder, which we'll be spending the rest of our discussion on today. But the worrisome aspects of REM sleep behavior disorder are those that occur during adulthood. Sleep disorders of childhood should generally be considered separately from those of adults. Dr. Avidan again.
There are some parasomnias that are normal for age. For example, children will commonly experience sleep terrors and nightmares and sleepwalking. We don't get too excited about those type of presentations because they do occur as sleep architecture matures. But it's inappropriate for an adult to experience parasomnias, and it's generally related to either sleep deprivation or a medication or an underlying primary sleep disorder that has yet to be diagnosed.
So moving on to REM sleep, also known as paradoxical sleep, because the brain doesn't really slow down, so to speak, during REM, as it would during deep sleep, which is also called non-REM sleep. REM sleep typically occurs about 90 minutes after the onset of sleep and tends to occur more frequently later on during sleep.
The brain activity resembles, interestingly, what you will see during wakefulness.
And to keep the body from acting out the experiences happening in your mind during REM sleep, there is a strong GABAergic and glycinergic inhibition of the alpha motor neurons in your brainstem and in your spinal cord, which prevent muscle activation.
Inhibits skeletal muscle tone.
But there is other physiologic activity during REM sleep, like the
inability to control body temperature, so you will have fluctuation of patients sweating a lot or feeling very cold.
And patients are generally more alert to their surroundings. They're more likely to wake up with just a little noise or a gentle touch. But while the patient remains in REM sleep, the skeletal muscles should remain paralyzed. They should.
The paradox is that in a REM sleep behavior disorder, which is a REM parasomnia, that muscle atonia is abnormal.
The skeletal muscle inhibitory processes fail, and now the patient acts out their dreams.
Shouting.
Oftentimes, it can be aggressive or disturbing.
Flailing of the arms.
Maybe they're being chased.
Or they're playing soccer and they are kicking their legs. And what's interesting is in the process, they are actually doing this in real life.
Which could awaken the patient's partner, alarm them, or even cause the patient or their sleeping partner any physical injury.
If they have a dresser next to them or a sharp piece of furniture or glass fixtures or a window. Just last week, I saw a gentleman who flew out of bed into a dresser, basilar skull fracture, C-spine injury, was seen in the emergency room, got admitted to the rehab unit. But the fact of the matter is they took care of his orthopedic injuries, but no one really asked, well, why did this happen? They wrote in the note that this was related to a nightmare.
In fact, the patient Dr. Avidan just referenced probably had an underlying REM sleep behavior disorder, which is important to know prognostically because the patient and the patient's sleep partner can be counseled about safety, but also because RBD rarely occurs in isolation, for kids and for adults.
It turns out that REM sleep behavior disorder in a child is narcolepsy until proven otherwise.
In kids, RBD very frequently co-occurs with nightmares, but also with excessive daytime sleepiness and narcolepsy, which is itself a disorder of REM sleep.
REM sleep behavior disorder in an adult raises concerns that in 5 to 10 year period, there is a 50 to 70% chance that the patient will develop a neurodegenerative condition.
So we finally arrived at RBD. What is REM sleep behavior disorder and how is it diagnosed?
This is a one parasomnia for which a sleep study is absolutely mandatory. One can raise concerns that the patient may have REM sleep behavior disorder, but you can't call it REM sleep behavior disorder until you do the sleep study.
Before the polysomnogram, before your sleep study, it may not be clear that what the patient is experiencing is REM sleep behavior disorder. The patient demonstrates some sort of arousal in the middle of the night, and with RBD, there's typically a vivid performance of the patient in their dream. We call this dream enactment behavior. But not all nocturnal arousals are RBD. Patients may have nocturnal seizures, which may look convulsive, or they may be associated with some abnormal posturing. Nocturnal panic attacks, which often co-occur with daytime panic attacks, are associated with elevations in heart rate, tremors, shortness of breath, sweating, and a sense of impending doom. They can take a few minutes to recover from, but they don't typically manifest with the same motor symptoms that we see with RBD. Sleepwalking, or somnambulism, is probably the most similar to RBD, but it's a non-REM parasomnia. And somnambulism is exactly as it sounds. But sometimes, the behaviors can be more complex than just ambulating around the room. The patient may fold clothes or rearrange the furniture, and because it occurs during deep, slow-wave sleep, the patient is less arousable during these behaviors. Ultimately, until you have done a sleep study, Many of these complex behaviors during sleep are clinically referred to as dream enactment behaviors.
Dream enactment behavior by itself, before we even have a sleep study, is called clinically probable RBD. Probable RBD. These are episodes of recurrent dream enactment, patients acting out their dreams, but we don't have a polysomnographic confirmation or a sleep study confirmation. On the other hand, we may have a sleep study which shows that the patient has abnormalities in their muscle tone. The muscle tone is not paralyzed. We can't call this RBD either. This has a different term. It's called subclinical RBD. But you really need both to have the clinical presentation of patients acting out their dreams, dream enactment, and you have to have a polysomnographic confirmation that muscle tone is elevated or augmented, and you have to rule out nocturnal seizures and other conditions that may look like RBD but are not. Only then can you make a diagnosis.
The diagnosis of RBD is cinched with the polysomnogram, but the sleep study does much more than characterize muscle tone and electrical brain activity.
A polysomnogram, as the name implies, poly means many, somno, sleep, gram, recording. It records a variety of physiologic functions that occur during sleep. The primary ones, they include brainwave analysis, eye movements, muscle tone, EKG, and then you have record the leg movement, say EMG, but also the arms. And you would also record respiratory channels, meaning you'll look at, say, airflow and effort,
which can be used to distinguish obstructive from central causes of sleep apnea. Obstructive sleep apnea being associated with respiratory effort, but impaired gas exchange, and central sleep apnea being associated with a lack of drive to breathe despite rising CO2 levels.
This is very different than some of the portable sleep recordings that one can order. And they do one thing and one thing only. They help support the diagnosis of obstructive sleep apnea.
So you have somebody in the sleep lab, they tolerated the polysomnogram, which has its own difficulties inherent to the study, and you make a diagnosis of REM sleep behavior disorder. What are the next most important steps in your management?
That's, I think, Dr. Sigler, you hit the nail right on the head, because probably the easier part of the evaluation is making a diagnosis of REM sleep behavior disorder, which has to be done clinically and using the sleep study. How one then discusses the implications of having the diagnosis requires a little bit more in-depth discussion.
You've seen this before. Your patients hear what you've said, they take what you've told them.
It's leptomeningeal carcinomatosis. The best medication for your son's condition is called nusinersen. The MRI shows a glioblastoma. You have a REM sleep behavior disorder.
And while they may trust what you're going to say next, what you're going to recommend next, you know that they're going to Google it later that night.
With Lewy body dementia and REM sleep behavior disorder.
The results of a condition that's often misdiagnosed.
And the information they might find online, as you know, tends to amp up the hype about everything.
There have been fractures, there's been subdural hematomas.
Drama sells.
Currently, there is no cure. Rig wears a patch.
So getting the right information to your patient and counseling them appropriately is all the more important nowadays. And that in-depth discussion that Dr. Avidan just mentioned.
And there are a variety of ways in which one would handle such a discussion.
It includes counseling the patient on the condition, reviewing the treatment options, but also summarizing the prognosis of RBD, which again, does not typically occur in isolation.
Has significant clinical implications for neurodegenerative conditions later down the road. I generally, before I order the sleep study, I tell the patient why I'm doing this, why I'm ordering the study. I tell them that right from the get-go, when I see them right at the very beginning, I tell them about the condition. I tell them that I'm concerned about REM sleep behavior disorder. And I tell them, I disclose in a very transparent manner that this is a condition predictive of future development of Parkinsonism and other neurodegenerative conditions.
Some might think Dr. Avidan is putting the cart before the horse, preparing the patient for a possible diagnosis that would be terrifying. Dementia with Lewy bodies, Parkinson's disease, multiple system atrophy, these neurodegenerative synucleinopathies. Personally, I fall into the camp of seemingly naive providers just looking for an answer. I wouldn't necessarily tell a patient who's getting an EMG that I want them to get that study to rule out ALS. Sometimes there's no need to make a patient panic before we even have an answer. But after hearing Dr. Avidan talk, now I understand why he does this for his patients who have probable RBD.
The reason why is if I tell the patient that they may have RBD, REM behavior disorder, and the patient then goes on Google or on the internet and they will find out about the neurodegenerative concerns, and they will be very upset that there was not a mention of that during the discussion. They will actually get scared and anxious. So I think it's really critical to let people know why you're doing the test. What is your concern? This is not only a concern about parasomnias. This is a concern that parasomnia may have a clinical signal of something else down the road. I'll tell you, in the last 20 years of practicing sleep medicine, there was one patient who felt upset that I told him about the diagnosis. And you know why? This was because the patient was afraid. The patient was in his 80s. He was afraid that he would be a burden when he does eventually get diagnosed with RBD and a neurodegenerative condition.
The advantage of knowing this, the awareness of the probability of developing dementia when you have REM sleep behavior disorder, some data indicating as much as 50 to 80% chance over the next 10 to 20 years. The advantage is the patient and the family can plan ahead for it.
If he wanted to travel with his wife to Europe, and the time to do it is now, not 5 or 10 years down the road.
Or if the patient's spouse also has some mild cognitive impairment or dementia, then planning for a transition into an assisted living facility or receiving support from other family members.
And it also helps people understand that if future clinical trials will come up focusing on RBD, that they know they have the condition, they know what the implications are, and they'll be more readily available to participate in clinical therapeutic trials.
How does your treatment or management change once you make that diagnosis, besides considering further follow-up for evaluation of Parkinsonism or DLB?
So when we make a diagnosis of a patient with REM sleep behavior disorder, treatment and management, in my view, are somewhat different in that treatment usually involves a drug. Management is more holistic in that it involves a drug, but also involves, well, how do you manage the patient in time? What do you tell them? We're treating the actual parasomnia by putting them on medications to prevent the aggressive behaviors at night, the ones that would lead to injury. But we also manage expectations that there is a follow-up, that given that the patient has an increased risk of developing a neurodegenerative condition in time, we have to manage follow-up expectations, manage the fears of the patient, manage their expectation that perhaps if they do develop a tremor or if they do develop some of the early signs of Parkinsonism, that we will be sending them for additional neurocognitive testing. And if they do phenoconvert and develop Parkinson's disease, that we then proceed to manage the symptoms of the movement disorder.
Dr. Avidan also recommends discussing all these aspects of management with the patient's family member or bed partner present, because they can provide a different perspective of the patient. The patient may not be bothered by the REM sleep behaviors, but the patient's bed partner may be losing sleep, or they may have sustained physical injury as a result of the parasomnias.
Disorder, because they're the ones who experience fear and anxiety about sleeping next to someone who is constantly punching and kicking, and they're afraid of when is the next punch going to come. And they're afraid
when asked upon waking, many patients report their dreams were unpleasant or violent, which explains why half of patients with RBD or their partners will have sustained some sort of physical injury before the diagnosis is made. The patient's family member or bed partner are also the ones who may end up helping the patient down the road through their visual and their auditory hallucinations, or with their cognitive decline as the neurodegenerative condition begins to manifest. And moving on to the specifics of treatment, Dr. Avidan first emphasizes safety.
Safety by removing sharp objects, barricading the wall. And I've had the patient was a FBI agent, always slept with the handgun under the pillow. And one night he woke up and there were 3 bullet holes on the ceiling.
Oh my goodness.
As part of his dream enactment. So you want to maximize safety.
And until the patient is truly safe, often the patient and their bed partner have to sleep in separate rooms. Then there are the medication options.
Melatonin is one. Clonazepam is a second.
Melatonin works by reducing the duration of REM sleep, therefore reducing REM sleep parasomnias. And it does this to a moderate degree, according to clinical trial data, between 40 and maybe 100% effective, depending on the outcome that you're assessing.
Melatonin is probably the safest and the most effective, and probably the one drug that actually restores normal muscle tone.
Paradoxically, benzodiazepines like clonazepam increase the proportion of time spent in REM sleep, unlike melatonin. So the effect of clonazepam may be mediated through its effect on dream content, as in less violent or aggressive dream experiences. In one prospective single-arm trial of 39 patients with RBD, 2/3 of patients achieved freedom from sleep-related injuries to themselves and their partners with titration of clonazepam. And other retrospective studies have confirmed that clonazepam can eliminate injurious sleep-related behaviors by 50 to 80%.
It does work really nicely, but it does have more side effects.
Both melatonin and clonazepam appear to be similarly effective, according to comparative observational cohort studies, but melatonin is the better tolerated, so it's recommended as first line these days.
In my practice, we usually begin with melatonin, and we usually begin at a high dose, and we usually recommend time release or sustained release melatonin. But I do want to preface that no drug to date is FDA approved for RBD.
To wrap up, REM sleep behavior disorder is a nocturnal parasomnia that occurs in children and adults. And in children, it often indicates narcolepsy. In adults, there's a 50 to 80% chance of developing a synucleinopathy in the next 10 to 20 years.
It's a sign.
Either Parkinson's disease, MSA, or dementia with Lewy bodies.
It's a sign of a neurodegenerative disease.
And RBD may be one of the earliest indicators of a neurodegenerative condition before the brain damage from the synucleinopathy becomes irreversible. Patients have 10 years or 20 years before the symptoms of neurodegeneration manifest. So recognizing it earlier has treatment implications for future disease-modifying therapies.
This is for the first time that we're able to actually intervene early in the course of Parkinson's to prevent it.
Also recall that RBD requires a polysomnogram for diagnosis because the condition can mimic other parasomnias like somnambulism, which occurs during non-REM sleep, and other conditions like nocturnal seizures. Effectively managing the condition requires provisions for safety.
The first treatment is actually safety,
particularly for the bed partner, reducing the sleep-related behaviors and injuries through medications like melatonin or clonazepam, and also counseling the patients on the probability of later development of Parkinsonism or dementia. Generally, symptoms of RBD are very manageable, but the development of a neurodegenerative condition in adults with RBD is one outcome that should be carefully monitored for. And that's all we have for you this week on Brainwaves. Special thanks to Dr. Alan Avidan of the UCLA Sleep Center for sharing his 20-year experience treating patients with this condition. As a reminder, Brainwaves is intended for medical education only and should not be used for routine clinical decision-making. This week's episode of the Brainwaves podcast was produced by myself, Jim Siegler, with the help of Dr. Alan Avidan out of Studio 3 in Philadelphia, Pennsylvania. Dr. Avidan reports that he's a consultant for Merck, and he's a speaker for Eastside and Harmony. Music for our program today was courtesy of Andy Cohen, Purple Planet Music, Steve Coombs, Jan Tarian, and Shane Ivers, whose music can be found at silvermansound.com. Our theme song was composed by Timothy Dalton, sound effects by Mike Koenig and Daniel Simeone. For more information about what was discussed on the show, as always, please take a look at the show notes for the references to the highest field literature on the topics. We've got quite a few of them this week. And follow us on Twitter at Brainwaves Audio. I'm Jim Siegler, and I'll talk to you soon.
Thanks for having me, Jim.
Sure. Take care. Have a good one.
You too.
Okay, bye.